Right here. So welcome to the Pharmacy Foundation's Genitourinary Immunity and Malignancy Q&A feedback. I'm Mohammed Imran. I'll go through a brief introduction in a few slides to come. Now, a short company overview then. If you just go on to the next slide, please. So Pharmacy Foundations, for any of those that did not attend the last month's Q&A feedback, you can feel free to watch that on our YouTube channel, or you can sign up through the website as well. There's a variety of things that we do work on. We work, for example, with undergraduate students, where I can see some of the names I do recognize with the University of Bradford, when we do a few simulated sessions for there, and a few of the universities as well up and down the country. That's your undergrad kind of side, as well as tuition and work-based learning placements that we're involved with, other things during the foundation year, and the kind of support that we try and give for yourselves is we have podcasts, we have online revision course, which you guys have, I think a few of the names I can recognize also from the course. So a few of you guys will have attended there, and we have these Q&A sessions in association with them. So you have your online revision webinar. A couple of weeks later, we'll have a drop-in session for any questions that you'd like answering regarding the particular topic. We'll also have a mock exam upcoming later on in the year that'll get released. Calculations masterclasses, these will be all online as well, which is a very good provision for the people that cannot attend on a specific day. And finally, there will be one-to-one tutoring as well upcoming very shortly. Postgraduate then, we've got CPD events, networking opportunities, and clinical simulation, all to come. Next slide, if you don't mind, let's crack on. And I'll just let a few more people in from the waiting room. So these are just some images that you guys actually may be in, some people on the call today. But we have hospital VR simulation, which is quite futuristic and quite engaging. We have a clinical GP simulation with an actual System 1 simulation suite that we've got. So we've built a small town within the simulation where you can travel around per se and have a look at different patients and different parameters and have a look at broader history really. Let's go on to the next slide then, just so we can get into the actual content. So this is the team. I'm Mohammed Imran, and I'm the General Manager, Quality Assurance Lead. I predominantly work in general practice as an advanced clinical practitioner. I'll see people on the day with acute presentations, and I'm quite nicely placed, I'd say, definitely for the GUM section at least, in the sense that often people present with these types of symptoms, and there's a variety of things that I'll quite routinely cover, and it's quite closely linked with that particular section. But a lot of the actual teaching aspects of this course in general will cover within general practice. So that's enough about myself, I think. There's a whole host of people on the team. We're very, very fortunate to have pharmacists with a broad spectrum of experience. In fact, I'm from general practice, a few more colleagues, in fact, from general practice, a few in secondary care, a few also in community pharmacy as well. So there's a large breadth of knowledge with the team. And then usually what we'll try and do is people that specialize slightly more, we'll try and give them the particular topics to teach on. So you are being taught by really experts within their field, but we're always toning it down so it's appropriate for your exam. Because ultimately, guys, it's all about trying to get through and passing that exam and being well-rounded pharmacists at the end of the journey. If we get somebody that's, for example, somebody that's a cancer expert, for example, right, and that's what they deal with day in, day out, understandably, you don't necessarily have to know lots and lots about that, okay? So what we need to do is have somebody that can tone the knowledge to what you actually need, okay? So hopefully that makes sense. Let's crack on to the next slide then, and these are just our social media handles. You can also see these on the right-hand side of the slides, but please do follow our Instagram page, especially because there's lots and lots of key pieces of information that are released there. And it's quite easy just to pop through, have a look at the story, interact with the story as well if you can, kind of like a pub quiz per se. We've also got a WhatsApp support group, which you guys can scan the QR code for now, as it's up on the screen. This is quite useful. We always mention different things and different for example, deadlines and such. For example, signing up for this course. A few people signed up yesterday, which is great, completely free, of course. So just do sign up to there as well. We'll just go on to the next slide then. So in terms of the content of the genitourinary and malignancy topics, we covered why on earth are these important. Okay, ultimately, like I said earlier, guys, it's about the registration assessment framework. That's what it comes down to. That's fine. We'll post the WhatsApp group link in the chat as somebody's asked for that. That's not a problem. In terms of the registration assessment, then both of these topics are medium weighted. Okay, and when we talk about medium weighted topics, guys, what does that actually mean? So if I'm telling you this is a medium weighted topic, how many questions, let's just say, would you typically get on medium weighted topics? Or even easier, what kind of percentage are covered with medium weighted topics within the GPHC exam? Ooh, 50% is a bit high. Any other bids? Any other bids, guys? Thank you for trying, by the way. Fantastic essay. Well done. It is, if you want to change your name, by the way, and I can refer to you with your name, absolutely fine. But if you want to leave it as essay, that's fine as well. It is 25 to 35%. So would we say it's quite important to know about these topics? Right? I think we'd all agree that it's very important to know about these topics, especially high and medium weighted topics make up the very bulk of the exam. So knowing them to a somewhat degree of detail is really important. Understandably, not to the same level that you might have to study the high weighted topics, right? But just one peg below. Okay, that's how I like to kind of think about things. Now, just as a very, very brief summary, in terms of the genitourinary system, we've covered complications, acute and chronic, urinary symptoms and their management, infections, as well as the management of infections and red flags associated with infections and things just generally to be aware of, as well as contraceptives and emergency contraception. Okay, so hopefully having attended that session, and if you're listening to this recording or if you're here live, you will understand a great deal about these, and hopefully we won't have any repeats of questions that are already on the sessions, which I don't mind going over again, by the way. So it's fine if you'd like to cover that again today. But moving on then, immunity and malignancy. With this particular topic, we've covered key terminology because, like I said earlier, guys, in terms of immunity and malignancy and cancers and such and so on and so forth, is not something, and I am going to make this point again and again, because it's very important. What I like to try and do and what all the team likes to try and do is explain to you the kinds of things that you need to be looking out for with certain chapters. Understandably, the genitourinary system, okay, is quite often prescribed in primary care, quite often dispensed in community pharmacy, and otherwise even in secondary care, it's often managed, okay? Immunity and malignancy, pretty much all the management starts in secondary care, okay? Often is kept within secondary care. So the level of detail that you need to know about genitourinary is probably a lot more than immunity and malignancy. Do you understand the rationale behind that? Considering they both even are high-weighted topics, okay? So for this then, the key things that we covered that we feel is really important for you to know about is the key terminology, the important drugs and their side effects to be aware of, as well as cancers and methotrexate. Okay, methotrexate is incredibly important to know about. I've got a slide on methotrexate just coming up in a few moments. Could we just go on to the next slide, please? By the way, just missed that point actually about there is actually 50 questions within both these sections. Okay, a total of 50 questions as well as case studies that are covered, so covering a whole host of these actual topics. So you may benefit from it. If you've not signed up already, make sure that you do have a look at that, as well as lots and lots of different revision posters. I think when it was OTC, we had loads. I think that was about 40 or so. I think with these sections, I think there's at least 10 to 15 or something along them lines. So there is quite a lot of content that's given to you guys. Let's go on to the next slide, please, guys. And right here. So the layout for this session then, we're going to hopefully you'll be able to populate your questions with Slido. So for those people that have not used Slido before or did not attend last month, all you have to do is literally go onto Google, type in Slido, click on the first link, and I'll give you a code on the next slide. And hopefully you'll be able to populate your questions, and we'll have a look at that towards the end of the section. If we just click again, we will answer your emailed in questions in a few slides to come. We're also going to, if we just have another click there on the screen, we're going to revisit popular sections of these topics for the people that did not attend, and hopefully you'll find this session quite useful in that regard. And people that did attend, I'll try and also, or have in fact already seen the recording, I'll try and add a bit more information to add to your breadth and depth of knowledge. And let's have a look at the next point there. We will cover some bonus questions, not from OTC, of course, on genitourinary and malignancy systems. And the last point here, we're going to be looking at the Slido questions. So then, talking about Slido, let's go straight on to the next slide then. So what I want you guys to do is go into Google. If we do this now, it'll be excellent. Go into Google, type in Slido, click on the first link, and copy over this code. So 2732720, or just copy it from the slides. I'll put this up on the next slide as well for you guys to copy over. Okay, really important that we try and populate that. You can give upvotes as well, which is quite useful for particular questions that that you think are quite useful, or that you were going to type in as well, and hopefully we'll try and cover them during this session. Okay, so let's go on to the next slide, which has also got the code on there. So for anybody that's not got the code, don't worry, it is going to be still present. So your emailed in questions, let's cover these first then. So the first question was regarding, I believe, the GUM system. So in the GUM session, you mentioned anticholinergics. What drugs do we need to know about for the exam? Very, very good question. Okay. Now, understandably, there's a variety of people on this that are going to watch this recording. If you are watching this recording now, as well as a variety of people that are on the live session with me today. Now, understandably, if you work in community pharmacy, this isn't necessarily something that you'll be covering every single day within your day-to-day practice. If you're in primary care, there's a high likelihood you'll be covering it at some point during your year. If you're in secondary care, you'll definitely be covering it as well. Okay, but do we need to know it for the exam? I'll tell you what you need to know for the exam. In terms of the drugs, okay, that have high anticholinergic burdens, that's the key thing that you need to be aware of. But if we just go back to the webinar, during the webinar, I talked about anticholinergic side effects when we were discussing the management of urinary frequency, urgency, and incontinence, right? So just remember back to the webinar when I discussed that specific slide, okay? That when we talked about the drugs that we use to treat these types of symptoms, is generally antimuscarinics, okay? They're the first line treatment often with these types of symptoms. So again, urinary frequency, urgency, and incontinence. Now, there are other medicines as well, but I'm not going to bother to cover them again today because we do mention these within the webinar, as well as the key MHRA alerts associated with them. So do revisit the webinar if you've not already seen this section. Now then, guys, what are the examples of antimuscarinic drugs? Let's see if everyone's with me today, if everyone's awake on a Sunday, or we're all having a lie-in. Just give me some examples, guys, of antimuscarinic drugs that may be used, in fact, in the management of urinary frequency, urgency, or incontinence. Any ideas? You've definitely dispensed some of these, or you've seen these within your pharmacy career. Anybody want to throw a wild guess out there? Fantastic. Solifenacin, oxybutynin, any others that we can think of. But that's a fantastic start. Well done, guys. Tolterodine, one more, starts with another T. So definitely you guys have attended the webinar, which I'm really happy about. One more that starts with a T. Trospium. Okay, so these are antimuscarinic drugs that we use in the management of urgency, frequency, and urinary incontinence. And I'm going to go through these terms for anybody that's not attended the webinar as well in a few slides to come. Okay, so then back to the actual question on the slide regarding anticholinergics, right? So in terms of antimuscarinics, okay, and these drugs, they work on acetylcholine receptors. Okay, so for the purposes of this discussion today, these two terms are pretty much synonymous. Okay, but why do we actually care? Why do we care about anticholinergics? What do we think? Why do we care about anticholinergics? Why are we worried about anticholinergics? What type of patients do we need to be concerned about taking a variety of anticholinergic drugs together? Certainly, we're worried about anticholinergic drugs in the elderly, but why? Why do we care about that? Risk of falls? Fantastic, fantastic. Key in increasing the risk of falls, okay? So elderly, for anybody that didn't already know, is defined as over 65s, okay? These drugs, anticholinergic drugs in general, are associated with a risk of falls and cognitive impairment within the elderly. And just to bring this point home, okay, this isn't something that you have to know for your exam, but just to get you guys to understand why we care so much about this is when people, you don't need to know about ACB scoring per se. If you've not got role in primary care or secondary care, it's unlikely you'll need to know this, but it's important just to be aware of, okay? Somebody with a high ACB score, and knowing that much is enough for you guys, I think. Somebody with a high ACB score that's elderly, they have a 20% chance of passing away within the next 2 years, which is very significant, versus somebody with an ACB score of 0, so if they're not taking any anticholinergic medicines, basically, versus somebody that's taking lots of different anticholinergic medicines, they've got a 7% chance of passing away in the next 2 years. So there's a 13% gap isn't there somewhere, okay? That's the issue with anticholinergics. That's why often when we are reviewing elderly patients, especially if they're attending with symptoms of delirium or have recently had falls, then of course, one of the key things that we want to be thinking about is the patient, are they taking any anticholinergic drugs? And just actually off-shooting slightly, guys, when we talk about risk of falls, what other kind of things, what other parameters do you think we'd want to be measuring or having a look at as well in terms of falls risks? Just a short tangent, we're going to come back to this particular question. What other kind of things do we want to be aware of? Electrolytes, yeah, electrolytes is possible, definitely. Anything else? Might want to check the username, the kidney function, BP, fantastic, fantastic. And right then, so playing devil's advocate, what about BP? Understandably, we're going to say if it's low BP, right? If the BP is on the lower side, but how do you define low BP? If you have a postural drop, what do you mean by postural drop? What's the actual, nice guidelines definition of a postural drop then? Is it greater than 15 or is it greater than 20? Greater than 20 usually, isn't it, in terms of the systolic or diastolic, either or, really. It doesn't have to be both, but it can be either. Is a systolic drop, right? And often these people will have symptoms upon standing. They're the kind of patients that we'll be prescribing a specific drug. It starts with an F. What am I thinking about? It's also a mineralocorticoid. That's how it works. What drug am I thinking of? Fludrocortisone. Fantastic, fantastic. And they're the patients that you might see on half a tablet a day, and then the dose will be titrated according to response. Fantastic. What other thing, though, is associated with false risk? Surely it's not just blood pressure. So we've checked the blood pressure, we've checked the anticholinergic medicines, everything's fine there. What other things are associated with false risk? I'm just getting you guys to think a bit broad on Sunday. Hopefully you don't mind. Hopefully you are benefiting. Certainly, hypoglycemia. Hypoglycemia is another key one, isn't it? And understandably, we want to be checking, if we're going to be checking after a meal, make sure it's 2 hours after a meal. When it comes down to hypoglycemia, the key thing that you want to remember is usually if it's blood glucose reading under 4, then they definitely are within hypoglycemic ranges, especially if it's 2 hours after a meal or upon waking even. Okay, so coming back to the question in hand, anticholinergics or antimuscarinics, which we're using synonymously for now. Back to the question at hand, what kind of side effects then do we need to be aware of with anticholinergic medicines in general? Now I'm going to classify this into 2 different parts. Okay, there's systemic side effects, which I'm sure you guys will have heard of, and we've already actually covered some of the central side effects, which are specifically delirium and risk of falls. But what are the systemic side effects associated with anticholinergic medicines? Constipation, dry mouth, blurred vision, urinary retention, anything else? One more key one. Oh no, it's actually, somebody's already mentioned the key one that I was thinking of, tachycardia. That's a really important one as well. Okay, fantastic. This is, by the way, covered in a lot more detail, down to minuscule or microscopic detail even, you could say, in our CNS section. I think that's in March, okay? But we'll cover it loosely today, at least. Now then, in terms of CNS symptoms, any others that we can think of then? I mentioned delirium, increased risk of falls. Anything else you can think of with anticholinergics, the CNS symptoms? I would say sweating is a more of a systemic symptom. Dizziness, yes, that's more of a CNS symptom, certainly. We've got disorientation. We've got agitation, right? So these are systemic symptoms associated with anticholinergics, just for you guys to be aware of. Also ataxia. Confusion is definitely there as well, certainly. There's also a risk of seizures as well, believe it or not, with anticholinergic medicines. Okay. Now then, there are a variety of drug classes, a large variety, as you'll come to learn in a few minutes, that have anticholinergic side effects. Do you guys know? Some of them are direct, by the way, such as antimuscarinics, right? This is a direct action on acetylcholine receptors, isn't it? Some of it is indirect. For example, you'll even have things like warfarin that has a very low score in terms of anticholinergic burden. It's not got a very great score in terms of anticholinergic burden. Okay? So some are direct, some are indirect. Now, what classes of drugs have anticholinergic effects then? TCAs, fantastic, definitely. Examples of TCAs then? Any other examples? Amitriptyline, we know that one already. There's 3 TCAs that I think you guys should know about. Amitriptyline is the next one. Sorry, nortriptyline, apologies. And there's one last one. They all sound kind of similar, don't they? One last one. Starts with an I, like me, and my name starts with an I for Imran, so it's I4, what is it? Imipramine. Imipramine is the last one. That also, fantastic. Well done. So We know antimuscarinics do, which we've already discussed, them type of medicines in some level of detail. We know tricyclic antidepressants do. What other medicines do as well? Which other medicines have anticholinergic properties? Benzodiazepines, yes, they do, but they are not high in terms of their anticholinergic burden per se. Okay, I'm just going to try and list the very key ones that you guys want to be aware of. Definitely benzodiazepines in terms of fall risk, etc. But in terms of specifically, strictly anticholinergic burden, they're not very high, believe it or not. Some antihistamines, fantastic, good point. Some antihistamines do have a high anticholinergic burden, right? But which antihistamines have a high one? Which type of antihistamines? First generation. And examples of first generations? Excellent. Any other examples? We've got chlorpheniramine as the first example. Any other examples that we can think of antihistamines? Because this is quite easily an exam question, isn't it? Review this patient's medicines, they were associated with a fall. Which of the following medicines are high cholinergic burden that may have been associated with the particular fall? Promethazine, certainly, and hydroxyzine as well. These three specific ones. Diphenhydramine doesn't actually have a high ACP as far as I'm aware, believe it or not. I think this may have a slightly different pathway that it works through, but it does have an ACP burden, understandably, like antihistamines do. So these medicines have a high one, whereas we've got the newer generation, right? The newer antihistamines, you could say, such as examples of newer antihistamines. We've got cetirizine, loratadine, fexofenadine. These have a lower ACP burden. Okay, so you want to be looking out and keeping an eye out for more so to do with the sedating antihistamines, specifically chlorpheniramine, promethazine, and hydroxyzine. Okay, so far we've covered three classes. We've covered antimuscarinics, tricyclic antidepressants, antihistamines. There's one more class of drugs that I think is important to know about because they have a high ACP burden. That definitely you want to know about for your exam. Anyone think about that? Anyone know? It's fine if you don't, guys. If you want to throw a guess out there as well, absolutely fine. Fantastic. Well done. Well done. It is antipsychotics. I'm really happy about that. Any examples then of antipsychotics that have a high anticholinergic burden? Anything that we can think of? The fact that we got to anticholinergic burden, guys, and we're only speaking, what month is it? We're in December, right? So we're quite far away from the exam, but just knowing that alone is impressive. Now, if you want to knock it out of the park, as they say, give me an example. Clozapine, that's a good example, certainly. We've also got haloperidol. Not sure if it's a high anticholinergic burden, to be fair with you. We've got olanzapine. That's a high one. Chlorpromazine and quetiapine, as far as I'm aware. So these particular classes, so these four classes, I want you guys to remember, okay, for your exam. So make a list if you've not made a list already. Antihistamines, antimuscarinics, antipsychotics, and tricyclic antidepressants. Okay, they've all got anti in there somewhere. So hopefully that'll be an easier way to remember it. And the rationale and the drugs associated with all these, I think we've made somewhat of a list. So if you've not made a list whilst I was speaking, please do watch the recording of this session. If you are watching the recording, just rewind back about 15 minutes when we started this conversation. Okay. Now, even drugs like benzodiazepines was mentioned earlier, they do have anticholinergic properties, but so does morphines, right? So you've got your codeine, tramadol, morphine itself, of course, You've also got fentanyl. These all have anticholinergic properties, but they are quite weak in the anticholinergic burden score per se. Okay, so let's move on then. Just remember, guys, the 4 classes. I think you'll be golden in terms of anticholinergic burden. We do cover this in a lot more detail, and we actually talk about the mechanism of the actual anticholinergic burden during the CNS webinar, which is again in March, which is going to be really, really useful, because sometimes you'll see when we're delivering these webinars and these recordings, we try and go into further detail, because when you understand the mechanism behind something, you will have already realized, actually, yep, must be antihistamines, must be antimuscarinics, must be antipsychotics, considering how it's actually working. Okay, so hopefully that's been useful, and hopefully that answers this question. This question was also actually on Slido, and somebody actually emailed it in. Might have been the same person, but it was a great question. It was a great question. So hopefully you guys found that quite beneficial. And please, every month, guys, do try and email in your questions, because it gives us lots and lots of things to talk about. Let's go on to the next question then. What kind of things do I need to remember about chemotherapy? Fantastic question. Okay, yet again, so well done to the people that are already switched on and already thinking about how I'm going to be tackling this exam in the coming summer. Well, like I said to you guys, chemotherapy started in secondary care, kept within secondary care. Okay. Let me just see. I'm just going to check one thing, guys. So, started in secondary care, kept within secondary care. Do we need to know absolutely everything about these types of medicines then? Anti-cancer medicines? No, right? That's the strict answer is no. What do we need to know then? Understandably, it's a medium-weighted topic, so they still can ask you questions about it. So for anybody that watched or has already watched the video of the malignancy section, when I go through the various key things to be aware of, I've kind of summarized it all for you. So I've been through this chapter of the BNF. I've picked out the key learning points. Okay, but for the purposes of this session, what I think is really, really important for anybody, for whatever reason, may not have purchased or may not watch the webinar for a variety of reasons, but just for your benefit, incredibly important that you at least look at the summary, okay, of the cytotoxic groups. Have a look at that section, okay. We summarize that obviously quite well, and we summarize all the key learning points from within the other associated with the other drugs as well within the topic. Key things that you want to know about is, of course, high risk of nausea, vomiting with certain medicines, administration of vinca alkaloids, important safety information on pregnancy and lactation, and all these key points are actually covered within the webinar. Right then, like I promised you guys earlier, let's go over 2 key slides. One slides from the GUM section, one slides from the malignancy section. I'm going to try and make it speedy because we've only got 20 minutes left, but hopefully you're going to find it quite useful. Right then, urinary frequency, urgency, retention, and incontinence. Okay, what do we mean by these terms? Okay, well, what is frequency? Frequency is how often something is happening, right? So how many times during the day something happens. Does that make sense? So what kind of things, right, can cause an increase in urinary frequency? What kind of conditions? What kind of acute presentations? Like urinary frequency. Type 2 diabetes, certainly. So you get polyuria as a key symptom of diabetes. UTIs, certainly. Diabetes insipidus as well, which is called diabetes, but it's not really diabetes per se. We've got UTIs, certainly. Anything else that we can think of? Well, urinary frequency is also affected by how much tea, coffee you drink, right? So if somebody is having BPH symptoms, you might actually tell the patient, try to reduce your tea, coffee intake, try to go caffeine free. Maybe don't drink fluids after 6 or 7 p.m. in the evening. If you need to have it, just have enough to just wet and moisten your mouth per se. Taking diuretics, fantastic, great points. I like it. Now we're thinking a bit more broader. Overactive bladder, lovely, fantastic. So if we go on, if you just click on the screen for the admin, please, if you don't mind. So then, yeah, again, this reiterates the points that we've all been able to pull together. How many times during a day you use the toilet? This can be associated with UTIs, increased intake of fluids, alcohol, caffeine, for example, diabetes, diuretics, also bladder cancer. Okay. Now, if somebody presents with symptoms of a UTI, but they've not got the burning sensation and they aren't positive when we talked about urine dipstick during the session, guys, and they're not positive for leukocytes and they're not positive for nitrites, and these terms are covered within the GUM section, right? Then we probably want to be getting something like an ultrasound done, just to have a look, is there any physical abnormality with the bladder or the kidneys? Is it a kidney stone? Is it a bladder stone? Because that can sometimes cause an increase in urinary frequency too. Okay, so then when we talk about urgency, well, if I say to you, you want something urgently, I want something done pronto, I want it done quick. That's what urgency means, in essence, in a nutshell. All right. What kind of conditions can be associated with urinary urgency then? And there is going to be some repetition, of course, between frequency and urgency. So what kind of things? Urgency, UTI again, certainly. Pregnancy can cause urgency, yes, certainly, because of the pressure of the baby on the bladder. We've got diabetes. Yep, diabetes potentially can cause symptoms of urgency, considering that you're going to want to be going more frequently. If you withhold, then of course that's going to lead on to urgency. Cool. Let's go. If you just click on the screen again, then so it's a hallmark feature of UTIs. So the key things that you want to be looking out for is, in terms of UTIs, is frequency, urgency, and dysuria, so pain upon urination. And these are the key symptoms, to be fair with you, that I check for during my clinic, as well as obviously the red flag symptoms of UTIs, which unfortunately I did want to cover today, but we've not got quite enough time, but I do cover it in a lot of detail during the GUM section. In terms of retention then, what's retention? What I hope you all retain from this session is knowledge and not urine, right? Understandably, we want to be retaining information. What urinary retention is, of course, the retention of urine, right? It's sometimes complete retention, or sometimes it's there's a slight amount of retention per se. Okay, so it's the inability to completely or partially empty the bladder. Now, this can be associated with a variety of different conditions. Okay, such as, what do we think? Retention can be caused by BPH, yes, certainly. Also, fantastic regarding the side effects from anticholinergics, of course. Anything else? Well, retention can become a secondary symptom following patients that have had strokes, right? Because they lose some of their bladder function, potentially. Not every person has a stroke, of course, but some patients do. Anything else that you guys can think of? Right, if we just click on the screen then, and let's discuss the points from the screen. We've got vaginal childbirth. Okay, understandably, there's a bit of trauma to the bladder during vaginal child delivery, which can lead to symptoms of retention. We've got pelvic injury and, of course, neurological damage as well. Moving on to incontinence then, what is incontinence? Well, if we're saying retention is the inability to, in that sense, pass urine, what's incontinence then? What do we think incontinence is? What do we think, guys? Incontinence is ... Fantastic. It's passing urine without control, in essence, right? Emptying the bladder without pressure, sudden leakage of fluid. Yeah, all of these types of things can be considered incontinence in some way, shape, or form. You can get fecal incontinence. In this particular slide, we're talking about urinary incontinence. Okay, a sudden leakage of fluid might be a bit. That's a difficult way, really, because if there's a pregnant lady, they could have had PPROM, which you don't necessarily need to know much about, but in essence, it's the premature rupture of membranes that causes the patient to actually leak the fluid that's normally around the baby. Okay, so I would say sudden leakage of urine specifically. Now, this is obviously, quite a broad term, really, in terms of the causes of it. What do we think are the causes of incontinence then? What can cause incontinence? What can cause you to just, unfortunately, wait yourself? Weak pelvic floor muscles. Fantastic. What's that known as then? Weak pelvic floor muscles, there's a certain term that we would define that as. Weak pelvic floor muscles, in other words, we would call that stress incontinence. Okay? There's other things as well. So if we just have a click on the screen, just to have the last box pop up, right here. So there is urge incontinence, right? So imagine somebody's got a UTI. They're trying to get to the bathroom. They can't get to the bathroom in time. And unfortunately, they leak some urine, right? That's urge incontinence, for example. There's overflow incontinence, where you're withholding urine for such a period of time where, unfortunately, you'll end up wetting yourself. That's usually due to retention symptoms. There's total incontinence as well. So total incontinence may be associated with a bladder injury. Okay. Also, incontinence is also a key red flag symptom for lower back pain, right? So lower back pain associated with incontinence is a symptom of what condition? It's a complete red flag. It's a red flag in community. It's a red flag in general practice, this particular condition. Might be helpful to also know that there is pain usually associated down both legs. They may also have fecal incontinence. They may also have saddle anesthesia. And usually some of these symptoms can kind of appear together as well. It's often acute onset. These are all red flag symptoms associated with lower back pain. And they all point towards a diagnosis of what? They point towards, guys, Claudia-Equina syndrome. Okay? That's a key diagnosis to be aware of, because understandably, do we think the GPHC can ask us about the management of low back pain? Yes or no? Certainly. It's a very common presentation, especially in community pharmacy, even in general practice. So knowing the red flags for low back pain is incredibly important. Okay. Unfortunately, I am going to go on to the next slide, because I do want to try and get to your questions on Slido as well. In terms of the particular symptoms, watch the recording. If you are watching the recording, then feel free to rewind if you didn't quite catch what I was saying. Let's talk about methotrexate. So, do you know when you guys somebody sent in a question regarding, well, what do we need to know about malignancy and immunity, that particular section of the BNF, medium rate topic? Well, you're guaranteed to get at least one question on methotrexate, and I'd be surprised if it was only one question on methotrexate. Okay, we do have a, for the last slide and for this slide, in fact, we do have a really nifty infographic on our Instagram page, so do look for that. You might have to scroll slightly down. Now, methotrexate, guys, what are the key points for methotrexate? Because I'm pretty sure you guys know already what's going to come up on the slides. What do we have to know about methotrexate? What do we think? Once weekly, fantastic. 99.99% of cases is once weekly. Very rarely it's twice weekly, but you'll never get a frequency greater than that. We have folic acid as another key point. Anything else that you guys can think of? I'm getting you to work for your money today, as they say. So folic acid is taken on the non-methotrexate days. It's a folate antagonist. Yep. Reports signs and symptoms of blood dyscrasias. And what does that mean? And it says you can't touch it. Yep, definitely not a good medication to be handling. It usually has its own counting triangle if you are in community pharmacy, because obviously it is a cytotoxic medicine. What do we mean when we say blood dyscrasias? Because it's just a term, really, isn't it? It's like me telling you guys about ataxia. What do we actually mean by that term? So blood dyscrasias, right? So when we monitor for methotrexate, we check a full blood count, we check urinase, and we check liver function. When we specifically talk about blood dyscrasias, we're generally talking about the white cell count, okay, which is part of the full blood count. So if that goes down, a patient is at an increased likelihood to pick up infections, okay? So it's very, very important if somebody is taking methotrexate that we monitor them, and if they do have symptoms, we'll be referring them back, okay? And as well as the blood test, of course, if it comes back abnormal. It's all part of the shared care agreement, which you don't need to know what it is, especially if you're not in general practice or secondary care even. It's not something that you're going to get questioned about in terms of shared care agreements, but being aware of the monitoring requirements for methotrexate, that's definitely something that you can get asked. Any other key points that we can think of then with methotrexate? Interactions? Yep. Which interactions? Trimethoprim, good. NSAIDs, very good, very good. Excellent. Right then, let's go through the slide together, okay? So if we have a click on the slide, the mode of action, of course, relies on antifolate activity, right? That's just how methotrexate works. So hence, other medicines that also have antifolate activity should not be given together. And the key one that you guys need to be aware of course, is trimethoprim. So if somebody comes with, it's quite nice that these two sections are together. If somebody comes with a UTI, you have an option of giving first line nitrofurantoin or trimethoprim. But if somebody is on methotrexate, you won't be giving them trimethoprim, will you? Okay, so hopefully that makes sense. And the next key learning point as well that you guys have actually mentioned is the usual dosing is weekly. Okay. The next bullet point you guys have also mentioned, so well done. Folic acid is given to counteract the side effects of methotrexate. Okay. Now, the next bullet point is regarding the antidote for methotrexate, which is calcium folinate or folinic acid even. Okay, very, very important that you do not confuse this with folic acid. Folinic acid, or sometimes called calcium folinate, and do not mix that up with folic acid. Okay, one's given IV, one's given orally. Understandably, if somebody's taken too much methotrexate, we're probably going to be treating them IV only as opposed to orally. So hopefully that will help you remember that point. The next point is regarding the monitoring. Okay, now, usually when somebody starts methotrexate, they'll have bloods before, and the bloods that we're going to monitor yet again, it's a full blood count, liver function, kidney function. We're going to do it before starting and every 2 weeks until the patient reaches their target dose at which whatever they're taking it for is in remission, so Crohn's or rheumatoid arthritis, etc. At that point, it'll be checked every 2 to 3 months. In the vast majority of cases, in terms of general practice, it's checked every 3 months. Okay, when things, of course, go abnormal, then of course it'll be checked more regularly. Now, the key symptom that you guys mentioned in terms of blood dyscrasias earlier, the key thing that we're looking out for is agranulocytosis. And this is something that we cover very well within our bloods section. Okay, that'll be coming up later on in the year. So I won't go into it too much, but the key term is agranulocytosis, which is the breakdown in essence of white blood cells. Okay. Now we also need to, the next point you guys have mentioned it in the chat, which is fantastic. So we are aware we need to avoid medications which are likely to cause renal impairment, because that will lead to an accumulation of methotrexate, which is of course not what we want, increased risk of toxicity, right? And the next 2 points are patients to report symptoms of blood disorders such as liver toxicity and respiratory ill effects. Now the last point there, it should be dispensed as 2.5 milligram tablets rather than 10 milligram tablets. When I did my pre-reg a number of years ago now, when it was still called the pre-reg, in fact, we did used to give out 10 milligram tablets, but that changed. Now we only give out 2.5 milligram tablets to prevent patients from overdosing inadvertently. Fantastic. So that is this slide covered, and I can pretty much guarantee you this slide plus my discussion plus what you guys have written into the chat is 99.9% going to come up within the GPHC exam. Okay, because you're definitely going to get one question on methotrexate, and there isn't really much else left in terms of methotrexate for them to actually ask you. Okay, right then. So we've got 5 more minutes left. Okay, let's go over to the Slido. Let's have a look at that, and let's take things from there. Okay. Let me just go over to the Slido myself, and let's see if you guys have put in any questions. If there's anything else you want to ask into the chat, if there's something on the Slido, then that's fine. But let's try and, I'm going to try and cover the questions on Slido first. Okay, that's fine. In terms of the question on Slido, everybody's just upvoted the question that we've already kind of covered, that was emailed in, as well as put onto Slido. So that's absolutely fine. Okay. And I think we're very close. We've got another 4 minutes left. If we just go over to the next slide, then in that case, which kind of ticks off this section. So let's have a look at the next slide. So that is OTC is done last month. GUM is done now. If we just click once more. And the next section is going to be on gastrointestinal and respiratory system. And we've got a fantastic pharmacist that is a specialist actually in respiratory medicine doing this particular talk. But like I said to you guys, just because they're a specialist, that doesn't necessarily mean that it's going to be very useful per se, right? What makes it useful is all of our tutors and all of our content is tailored for your exam. Okay, that's what makes things useful. So for me to say, oh, I'm a specialist in something is not necessarily beneficial if I'm talking well off the script of what's going to come on your assessment, registration assessment, right? So that's hopefully what we try and do. And that's what my job is as a general manager in quality assurance, that everything is backed up to the GPHC syllabus. So we can get you over the line, so we can get you passing that registration assessment. You will see me and hear from me, hopefully, again, with the cardiology section, which is another key topic that I like to teach on in January. I look forward to seeing you guys then. Do you guys have any more questions that you want to pop into the chat? I am still here. And here's the actual WhatsApp support group QR code. I'm going to stop the recording now. So if there is anything that you want to recover, that's of course within the recording, feel free to rewind. For anybody that's here live, feel free to, of course, watch the recording if there's anything that you've not quite picked up, but I have covered. So let me just stop the recording